Hello everyone, today we'll be presenting Case 9, John's Head Injury. Case Study Overview. John Doe is an 18-year-old male who arrives with his parents to the sports clinic where you are the nurse. When playing hockey this morning, he slid into the boards head first. He felt lightheaded at the time but was able to get up and finish the game. Your patient asks, "How long will I feel like this? I have a finals game next week."
On assessment of neurological status, John has a Glasgow Coma scale of 15. He experienced no loss of consciousness on injury, but did experience some lightheadedness. He has a headache rated 3 out of 10 on a numeric pain scale and experiences dizziness with fast movement. On examination of his mental status, John reported being a bit foggy, indicating a potential change in cognition for orientation and attention. John recalls the events of his injury and has no memory impairment. John's pupils are equal, round, and reactive to light and accommodation. On assessment of his cranial nerves, John's experienced dizziness with movement and lightheadedness may indicate cranial nerve 8 being affected. There are no other findings that indicate injury to John's cranial nerves. Assessment of cardiovascular status shows normal findings. John has a heart rate of 80 beats per minute, a blood pressure of 118/72, and is afebrile. Assessment of respiratory status also shows normal findings. John has a respiratory rate of 16 breaths per minute and an SpO2 of 99% on room air.
Gastrointestinal assessment. John is experiencing nausea and no vomiting. Integumentary assessment. John have no bruising or specific tenderness on head. Musculoskeletal assessment. No cervical spine pain on palpation and no paresthesia during range of motion. John is able to actively rotate neck, stating no paralysis. John balance and coordination exams is normal, and John reflexes are 2+, which is normal.
In addition to focused and physical assessments, obtaining a baseline through understanding John's past medical history can facilitate better care that best suits his situation and needs. As seen in our concept map, a history of previous concussions within a year yields the greatest priority related to concussions, followed by bleeding disorders, orthostatic hypertension, and hypoglycemia.
For diagnostic imaging, a head CT is done to rule out subdural hematoma. In terms of labs, a coagulation panel will be done to ensure that John's PTT, INR, and fibrinogen levels are within normal limits. Analyzing John's CBC, electrolyte, and glucose levels can rule out anemia, hypoglycemia, and electrolyte imbalances as causes for his dizziness and nausea. The diagnostic tools listed on this slide are used in conjunction with assessment and diagnostic testing to determine if John has a concussion and the severity of his injury. These tools measure eye opening, motor and verbal response, balance, level of consciousness, and symptom severity.
One of our diagnoses was subdural hematoma because the patient presented with headache, dizziness upon position changes, and feeling foggy, which can be a precursor of confusion. A subdural hematoma is an encapsulated pooling of blood in the subdural space that can originate from a blood vessel that burst after the impact of the head injury. Pathophysiology consists of three simultaneously occurring phenomenon. First, inflammation, where inflammatory chemicals such as interleukins and growth factors stimulate membrane growth and cause fluid to accumulate in the area, adding to increasing intracranial pressure. Second, angiogenesis occurs where fragile blood vessels form inside the capsule containing the collection of blood. These vessels can burst easily and the hematoma can become a hemorrhage as the injury propagates, leading to increased intracranial pressure. Third, fibrinolysis occurs and increases the bleeding as the prothrombotic factors are broken down and anticoagulant factors increase, so blood clots do not form readily to stop the bleeding. For this reason, a coagulation panel to screen for coagulopathies is helpful while awaiting CT or MRI results. Although in our case study, the imaging results do not indicate a subdural hematoma or hemorrhage, which rules out the condition. However, doing a coagulation panel would be necessary if there are many manifestations of a hematoma, hemorrhage, or increasing intracranial pressure at baseline.
The next possible diagnosis is a contusion, which is also known as the bruising of the brain and occurs when blood capillaries rupture due to injury. Signs and symptoms include loss of consciousness and cerebral edema. Severe cerebral contusions can lead to neurological deficits and hemorrhage. Contusions due to impact are often seen in the frontal and temporal lobes as pictured on the diagnostic imaging below. There are three types of contusion injuries. Coup injuries are where there's a contusion at the site of the impact. Contra-coup injuries is where the contusion is at the side of the brain opposing the impact. Coup-contra-coup injuries are a combination of the two. Based on our team's assessments and diagnostics, our chosen diagnosis for this patient is concussion. A concussion is a mild traumatic brain injury that is caused by the transmission of biomechanical forces from an injury to the head or body. Due to the insult to the brain, neuronal dysfunctions and cellular injury occurs. Calcium, potassium, GABA, glutamate, and other substances are released following cellular injury. Large release of neurotransmitters and other substances disrupts normal cellular communication and causes some of the symptoms which we will describe shortly. Cerebral blood flow also decreases, which can result in a loss of consciousness which occurs in less than 10% of cases. Children and young adults less than 25 years of age are at a high risk for TBIs as their tissue is still developing and cannot recover as quickly as an adult fully developed brain. The main reason why our team chose to focus on the clinical diagnosis of concussion is because the client had clear brain scans and normal labs. In subdural hematomas and contusions, the client may have abnormal brain scans and abnormal labs as well. As well, the client had a GCS score of 15, and those who sustain a concussion will generally have a GCS score of 13 to 15. The client additionally exhibited some clear markers of concussion, including having a headache, nausea, dizziness, and brain fog. Some other common clinical manifestations of concussion include impaired memory, impaired sleep, inattention, secondary mood disorders, photosensitivity, nervousness, and irritability. These manifestations typically last 24 hours and resolve by that time, but 10 to 15% of individuals will experience persistent symptoms for up to 1 year, and this is called post-concussion syndrome.
Symptom management is one of the primary interventions for John. Non-pharmacological methods should be used in conjunction with medication to help alleviate some of the concussion symptoms we discovered upon our initial assessment. Interventions such as dimming lights and decreasing noise levels can help reduce symptoms of photosensitivity, phonosensitivity, dizziness, and nausea.
Medications for concussion management include NSAIDs and acetaminophen for pain, medications for secondary mood disorders such as antidepressants and anti-anxiety meds, sleeping aids, antiemetics, and psychostimulants.
Following a return to sports, school, and work protocol is an essential intervention, especially considering that John asked us about when he will be able to return to his sport. Return to sports and school protocol follows a stepwise process of gradually performing schoolwork, sports activities, and activities of daily living. This stepwise process is described on this slide, which is the same information on our map. With this stepwise progression, the athlete should continue to proceed to the next level of activities if asymptomatic while performing activities at the current level. If any post-concussion symptoms occur while following the stepwise program, then the patient should drop back to the previous asymptomatic level and try to progress to the next level after a period of rest has passed. This intervention is really closely linked to patient education because the patient needs to be the one to recognize if symptoms are returning and accurately describe these symptoms during reassessments. As shown on our map as well, this intervention is also heavily linked to interprofessional collaboration, since people like John's coach are responsible for making sure he does not work himself too hard during gradual return to sports. The physicians and nurses are responsible for taking frequent assessments and more.
For interprofessional collaboration, there are quite a bit of people involved. There is the primary care provider who should monitor for abnormal signs and symptoms in recovery period and for evidence of post-concussion syndrome. The occupational therapist is to aid in independently performing ADLs with modified environment if needed. There's the physiotherapist to alleviate motor symptoms and strengthen muscles. The social worker for therapy referrals and assisting with post-concussion issues and emotions. The psychiatrist and neuropsychologist is to screen for depression and or anxiety in the first few weeks following concussion. As the risk increases, they are also able to assess physical and emotional functioning of the patient. There are the teachers to create accommodations for schoolwork and form individualized learning plans. And the team coach So how to work with him to slowly incorporate John back onto the team safely via modified play and how to prevent future concussions, such as helmet modifications.